after having learned the normal variations, if Dr. Ulhas is already joined there and he's ready with his presentation, I will be requesting him to make his presentation on approach to tachyarrhythmias, how far we can go. I know 30 minutes time is too small a time for giving the approach to tachyarrhythmia analysis, but I'm sure with the expertise and experience of Dr. Ulhas Pandurangi, he'll be able to do that. I once again request all the participants and thank all of them for having joined, and keep putting your questions into Q&A box as well as in a chat box. We will answer them later on. I thank Microlabs for creating this platform and supporting the technical support for this webinar. Thank you, Desai. That was a wonderful presentation. Over to Dr. Ulhas, and I request Ulhas to start making initial remarks and share his slides for presentation.
So I hope I am audible, Dr. Basanagaudappa.
Yes, you are audible.
It's my pleasure, and actually, it's a long time wish from my side. I needed to come to Mysore, to come to your institute, and to talk to you, and to talk to your students. Nagaraj Desai had been my good friend, had been always telling me. So, it's a great opportunity. Maybe thanks to Corona, I think. Otherwise, it would not have been happening.
We were forcing your wife to bring you here to Mysore.
Absolutely. I am a Kannadiga, sir. Kannada maatradtini, sir. Nanu Dharwadavanu. So, it's such a great pleasure. Thank you, Nagaraj Desai. And I hope, that French poet of yours who insisted that you should look for, the larger scenario, like the sea. You got to make the people to love the sea if they want to ship or build. So, my talk, I think, may encourage people to look at the tachycardia ECG from a larger perspective and not necessarily the QRS and the P waves. So, and then the title also, I think it's very interesting how far we can go was I hope my slide is seen now. I hope so. No, it is not the one.
We are able to see your slides.
You can see that.
Yeah.
Right, okay. So thank you, Dr. Basanagaudappa and Nagaraj Desai. It's a privilege for me. It's an interesting topic we are discussing here, not necessarily looking at the ECG diagnosis of tachyarrhythmia, but how far we can go on the basis of the ECG. That is what my friend Nagaraj Desai had insisted, and I hope I do some justice in the coming 25 minutes. See, basically, when we look at the ECG during tachyarrhythmia, of course, our aim is to make out certain differential diagnosis broadly. For example, could it be an SVT or a VT to begin with? Then we need to be doing some kind of a confirmation of the diagnosis. The confirmation of the diagnosis could be made on the basis of the ECG itself. For example, VT versus SVT. If you say VT and there is a AV dissociation, that's almost like diagnostic. But then if you really would like to look at what is that type of a VT, whether it's a ischemic VT or maybe it's a idiopathic, we need to be looking at little more into the details of the ECG by looking at, say, for example, QRS morphology, which is abnormal. Maybe it is not idiopathic. So there are ways of confirming the diagnosis on the basis of the ECG. If sometimes it is not confirmatory, but then you'll have to go for some other investigations, maybe imaging, maybe EP study, etc. When we look at the ECG during tachyarrhythmia, we also looking at a little more, just that more than making the diagnosis. For example, what acutely would like to do. Whether there are any kind of signs in the ECG which will tell you that, look, we need to be acutely treating this, or maybe there is a tachyarrhythmia, hang on, we need to investigate this patient further. Just do not worry about this ECG. Maybe is there any scope like that to plan? Of course, any abnormal ECG, we need to be doing a long-term management. And after doing this kind of an exercise, ultimately, we've got to be telling the patient what is the prognosis. For example, if it's idiopathic, say ventricular tachycardia, and if there is there is definitive therapy. If the patient undergoes well, he doesn't have to even recollect that he has had that problem. And if there is, for example, a tachycardia and there is a substrate, for example, a dilated atrium, or if this patient has had a myocardial infarction and if that particular ECG shows a ventricular tachycardia, well, treating that particular episode is not going to make him all right forever. So we got to be making the so-called prognosis on the basis of the ECG, which is documenting the tachycardia. So I'm going to be discussing some case scenarios here where all these things are going to be considered. For example, let's begin with a ECG. See, whenever we look at the ECG, the first thing is not to see the ECG. You got to actually listen to what is the problem, why the ECG was taken. Maybe you got to take a good history. And for example, all the students must have been told by their teachers that when you look at the X-ray first, why are you looking at the X-ray? Why the X-ray is taken? What are the symptoms? Then only you would be able to read the X-ray. The same thing there with the ECG. I would prefer people not to open the ECG. When a person is given an ECG, I would rather ask the person to stop looking at the ECG before you could make some mental diagnosis of what could be the problem and what you are looking at the ECG. Then only what the mind sees, the eyes see. What the mind thinks, the eyes see. So it's all the more important that, for example, in this case, is a 15-year-old girl with chest pain and hypertension. Well, we should remember that tachyarrhythmia can also cause hypertension. Tachyarrhythmia can also chest pain. And if the ECG is taken, well, one should be thinking whether it could be a tachycardia. Not necessarily a girl of this age should be having, for example, a coronary artery disease or a pericarditis or a myocarditis when everything was okay and suddenly she developed chest pain and hypertension. Maybe there can be a tachycardia. And if this girl was doing all right, then what could be the one which you could be seeing in the ECG? Most likely it could be a narrow QRS tachycardia. So with this kind of an assumption, we should be starting looking at the ECG. So this is the ECG. Now, this is quite remarkable. And when it comes to the hypertension part, well, whenever there is such kind of a rapid ventricular rate, even if it's a sinus tachycardia, maybe there can be a hypertension. But then this doesn't seem to be a sinus tachycardia because there are no P waves seen. This is seeming to be a regular, a narrow QRS tachycardia. And then there are no P waves seen clearly preceding the QRS. It's kind of a very, very rapid. It's about 280 beats per minute. You have some kind of alternance. Here, there's a QRS is of a higher magnitude. But what is more important is the ST segment depression. This is quite remarkable. You have a global ST segment depression and ST segment elevation in AVR. And then this patient has chest pain. Are we dealing with something called critical left coronary artery disease? Well, it's quite unlikely. This is a 15-year-old girl. And this is not a sinus tachycardia. So this probably ST segment depression is nothing to do with the so-called global ST depression and the AVR ST elevation associated with left coronary artery disease. Then this ST depression, does it really help us in making the diagnosis? So we are putting all these things together and we are saying that this is a regular narrow QRS tachycardia happening in a young girl who had been doing otherwise all right. The P waves are not seen before the QRS, but what is significant is an ST segment depression. So with this information, can we make any differential diagnosis? Yes. At least VT could be ruled out here because VT is supposedly to be a wide QRS tachycardia. So this is most likely an SVT. What are the commonest SVTs in a girl who is otherwise doing well? Clinical examination shows a normal heart. It could be one of the commonest of the supraventricular tachycardia, and those are AVNRTs or an orthodromic tachycardia, which is called AVRT, or atrial tachycardia. Younger the age, for example, less than 30 years of age, and if you have got a regular narrow QRS tachycardia and such ST segment depression, it is usually AVRT. And the more the ST segment depression with the associated with the narrow QRS tachycardia, more is the possibility that it is an accessory pathway associated tachycardia, and that is what is called atrioventricular reentrant tachycardia. So this particular patient who has had chest pain and hypertension turned out to have tachycardia as the cause for her chest pain and hypertension, and that tachycardia on the analysis of the ECG, regular narrow QRS, very rapid rate, may be associated with some kind of alternance, significant ST segment depression is most likely AVRT. If the same thing happening in an adult, for example, 40 to 50 years of age, even then this kind of an ST segment depression should not be considered as a manifestation of coronary artery disease. That would be most likely because of a pathway associated tachycardia. Now, about the management, if I ask the participants to vote what they would be choosing, what could be the first thing to do? This girl is under distress. She is having a chest pain. She is having hypertension. What could be the first thing to be done? Is it a cardioversion? Or, looks like this is such a ST segment depression, elevation in AVR, coronary angiogram? Well, I already told this is not the answer. Could it be ice cold water, or could it be verapamil? I know because of the time constraint, there will not be voting here. I would say that direct cardioversion could have been a great choice, provided it is a simple measure. Direct cardiac electrical cardiac version, is a painful thing. You require so much of a paraphernalia. You need to be preparing the patient, taking the consent, etc. Most of the SVTs are amenable for vagotonic maneuvers. For example, if you have an ice cold water, and if you think you have a big pan and then fill it up and then just throw on her face, well, it most likely is going to be terminating. Well, verapamil and diltiazem can also be given, but then if you are given these choices, if this is available, ice cold water is the right thing to be done. And so this patient with a narrow QRS tachycardia, which in all probability it's AVRT, vagal maneuvers are the best choices. Maybe Valsalva maneuver could be all right, but ice cold water is also equally effective. Adenosine, which has not been given as a choice, could also be tried, even when there is a hypertension. That's most important, because adenosine's efficacy or adenosine lasts only for a few seconds, at the most a minute, and it's reversible. Adenosine could very well be tried when you think it is a narrow QRS tachycardia, and typically in young people with normal hearts, even if there's a hypertension, before doing a cardioversion, which is more painful and is associated with more of resources, one can try vagal maneuvers. How about the long-term management? Well, if this particular episode was reverted with some of those vagal maneuvers, and you can actually send the patient home without any medications if this is a first episode, because we do not really know whether these episodes are going to be happening again and again. Most often these episodes happen, not really very frequently. They may occasionally only they may occur frequently. And the medications, what they are prescribed for such kind of a regular narrow QRS tachycardia, which could be considered AVRT, in the end, I believe either they should undergo radiofrequency ablation or nothing, because if you give the medications, it's not very sure whether they will have a breakthrough episodes. It is better not to even consider any more therapy, including the RFA, if this is a first episode. If this is a first episode and that was not associated with the syncope, well, you can reassure the patient. You may even send the patient without any medications, because we are not very sure whether the medications would really help. However, if there are 2 or more episodes, one may consider a drug therapy or a definitive therapy like radiofrequency ablation. One episode, however dramatic it was, if it was reverted, there is still a scope of managing the patients without medications. Well, what one could expect if there is a ice cold water which was splashed on her face, and then if it was successful and the sinus rhythm was achieved. I was talking that this was a regular narcotic tachycardia, and then there's an accessory pathway mediated tachycardia. So when there's a sinus rhythm, well, there is a possibility of the patient showing the pre-excitation, because it's an accessory pathway mediated tachycardia. But one should remember that the accessory pathway mediated tachycardias are usually silent on the ECG. They are not manifest. They are called concealed accessory pathways. But in this patient, after splashing the water, the diagnosis was much more definitive, because she showed a delta wave and a shorter PR interval, what we typically call WPW syndrome. So this girl, 15 years old girl, has a WPW syndrome where she, during the sinus rhythm, manifests pre-excitation, and she had one episode of palpitations, which was a regular narcotic tachycardia with significant ST changes, and it was reverted with adenosine. And she went home with just a reassurance that do not just worry. If you get the palpitations, wait for a while at home. Don't get panicky. It may actually revert, and then you do not have to rush to the hospital. But if it continues to remain for longer than, say, 15 minutes, half an hour, and if you start developing some kind of sweating, etc., then only you may come to the hospital, and then we will do a simple job like splashing water or giving you an injection, or you may actually induce some vagal maneuvers at home. For example, teach her Valsalva maneuver, or maybe she can induce vomiting by pushing 2 fingers into her throat deeply. Now, these are the things, and if such things happen again and again, or if the patient or the parents really are very concerned, you may consider drug therapy or radiofrequency ablation. But by and large, they are very benign, and they do not really cause any catastrophe. So we look at another case here, who is a 61-year-old male. He has palpitations for 3 months, and he comes to the hospital because he had a syncope a day before. A few more things about his history, which is remarkable. He has had myocardial infarction, was admitted in the hospital for a few days. That was about 3 years back. He undergoes a regular checkup every year, does very well, and even the latest of his echocardiogram was not bad. There's some kind of a moderate LV dysfunction, which is 40%, and he had been doing very well. When he visited the hospital, he really looked in good spirits, and there were no other symptoms at all. But he has palpitations once in a while for the last 3 months. So what could be the ECG when the tachycardia was documented? So now let's have this thinking here. This patient who has the coronary artery disease, old MI, if he has palpitations, well, he could have any tachycardia, but any patient with the old MI who has palpitations and who had an episode of a syncope, unless proved otherwise, we should consider those episodes are because of a ventricular tachycardia. The reason why we should consider that as a ventricular tachycardia is because that could be potentially life-threatening, and we need to be doing a lot of work to prevent him from developing sudden arrest. So before showing the ECG, one should consider that most likely the ECG is going to be a wide QRS, regular tachycardia, and then that could be a ventricular tachycardia. So now let's open the ECG, and this is the ECG. Well, we are surprised here. We were expecting a ventricular tachycardia because this patient had palpitations and syncope and is a coronary artery disease. Well, what is this ECG? This is a narrow QRS tachycardia, which is irregularly irregular. The commonest one is atrial fibrillation. Then how does the atrial fibrillation explain the symptoms? Well, it can cause palpitations, correct? How about syncope? Very rare, but occasionally a sudden onset of atrial fibrillation, especially when it is associated with the rapid ventricular rate response, is associated with syncope. So this could very well be the reason for his syncope. But we discussed if the patient had a myocardial infarction, if his ejection fraction is subnormal, we should think in the presence of a syncope, it could be a ventricular tachycardia. So this ECG, one should not just say that, well, okay, this is atrial fibrillation, you could have had a palpitation and syncope. This mistake should never be done. We got to pursue on this particular case further. Patient with old MR had a syncope without any kind of a documentation of a tachyarrhythmia. Even just a ECG is an alarming event because he is at risk for sudden cardiac death. We need to be doing a lot more hard work than just saying that this patient has an atrial fibrillation. What we should do? Well, at least in this particular ECG, you have taken what? Limb leads only 1, 2, 3, AVR, AVL, AVF. At least take the complete 12 lead ECG before you start making a comment that, oh, this is atrial fibrillation and we can be relaxed. So let's take the complete 12 lead ECG here. So what is the 12 lead ECG? By the time we complete the ECG, what it is happening is the patient is now showing a wide QRS tachycardia. What was there initially a irregularly narrow QRS tachycardia now has become almost kind of regular. Maybe a little bit of irregularity is here, but it is not as irregular as in the first part of the ECG. And this is a wide QRS tachycardia. Well, we already know that an atrial fibrillation patient sometimes can have aberrancy, and that aberrancy will lead to a wide QRS tachycardia. But then we also know that when there is an atrial fibrillation gets into a wide QRS tachycardia, there has to be a reason for that to become the aberrantly conducted QRS. Usually, when there is wide QRS during an atrial fibrillation, the preceding RR interval of a wide QRS is usually longer. And that's what we call Ashman phenomenon. So this wide QRS is paradoxically associated with a shorter RR interval as compared to this RR interval. So this is very unlikely that this is an aberrancy. Well, it is very tough to make a diagnosis of a VT only on the basis of these 3 leads. And especially when there is an AVR which shows negative QRS complexes, appears to be against a ventricular tachycardia. Well, there are certain ventricular tachycardia where, for example, outflow tract ventricular tachycardias, for example, can have it in the inferior leads, the R waves tall and the AVR negative. So it could very well be a kind of outflow tract ventricular tachycardia, and it is extremely rare to be associated with an aberrancy during atrial fibrillation. So,
Ulhas, can you go back to case number 1 ECG after splashing water? Somebody has asked a question to point out the delta wave.
Right. So this is after splashing the ice cold water. I hope this ECG is seen. All right. So now let's look at the PR interval. can you see, for example, in lead 2, there is no PR segment at all. So this obliteration of the PR segment, it should raise a suspicion that there could be a pre-excitation. Let's come back to V3. You have a P ends here, and then there's no PR segment, and then you have a kind of a delta wave here.
Yeah, the next lead is well seen. Yeah.
Yes. So now the question is, why it is seen only in few leads? Because some phenomenon could be seen, or some wave pattern could be seen only in few leads. Einthoven and his descendants have given us 12 leads. So the argument should never be why this is not here. Well, there are 12 leads. 12 leads are there only to capture the global picture of the heart. So I respect the person who suspected that it might not be there, but now I hope he is clear that, you know, this is known as a very subtle delta wave, but it becomes more significant delta here. So I agree. And for another reason to consider that this could be a pathway, look at the V1. Well, it could be a normal variant, but then this also has a subtle delta waves. And then what is important is V1 showing R bigger than the S, and the V2 showing, this is known as an early transition. This early transition is another feature of a left-sided accessory pathway. Now, lead 1 and AVL, if you see, this does not fit into a normal variant. Left-sided accessory pathway tend to have either a negative delta in lead 1 or AVL, or completely negative complexes in AVL. So this AVL even tells you that the accessory pathway is where the AVL is recorded, and that is left anterolateral area of the mitral annulus. So much.
Thank you, Ulhas. I think we can proceed. Sorry for dragging you back. That was one of the questions.
So, you know, it was an interesting question, by the way. So we are dealing here with something interesting. We did not go by this so-called misleading event of irregular narrow QRS tachycardia as the event which was responsible for his palpitations and syncope. We don't go by this ECG at all. Even if the ECG is like this, I would, or everyone should consider, or we should work towards ruling out the possibility of the occurrence of ventricular tachycardia. And that is what happened. Your patients paid, you continue to record the ECG, and then you have this white QRS tachycardia, which is regular, and it doesn't appear to be related with aberrancy. And then the further leads in the presence of an atrial fibrillation, you notice here, we got the QRS complexes, at least in AVR, AVL, AVF, and all the precordial leads, including V1, V2, V3. The interesting part is you have a wide QRS tachycardia, and then going on to a narrow QRS tachycardia, whose rate is almost similar to this wide QRS tachycardia. So ruling out essentially that this wide QRS tachycardia is because of aberrancy. So the point here is, if you have got a person with old MI, palpitations and syncope, whether you have a ECG evidence or no, you should consider that it could very well still be a ventricular tachycardia. And if for some reason, if the person has got a tachycardia in the form of, say, for example, atrial fibrillation in this case, we are not going to be simply be sleeping over that fibrillation episode. We should be still looking at further investigations, and we should be even looking for a Holter in case if this is not obtained. It is possible that the Holter Holter to pick up this. Holter could also help us in analyzing these atrial fibrillation episodes. For example, how frequent they are, how fast they are they preceded by atrial premature beats or a non-sustained atrial tachycardia degenerating into atrial fibrillation. All this you should be pursuing. Not necessarily in this case, any case with a paroxysmal atrial fibrillation, we got to be pursuing because the therapy becomes easy. If it is a multiple PACs which are inducing the atrial fibrillation, then targeting those PACs might help in preventing the atrial fibrillation episodes. If these atrial fibrillation episodes happen, for example, during the vagotonic phases, well, you have a different type of therapeutic measures to be adopted. Let's now go for some interactive phase here. If the person undergoes the Holter and then Holter confirms here that this is VT, you know why? Because there were episodes of paroxysmal AF and they continue to be like this. And then there were PVCs of the same morphology. And then there were episodes of NSVT without the AF. So it became very clear that this is ventricular tachycardia and this is atrial fibrillation. Now, if I ask to pick a right option, what could it be? So let's go to the history again. 61-year-old who has this episode of syncope and palpitation 3 months, and I told you he has been doing great otherwise. So if I ask to pick up a right option, what could be the right option? To do a coronary angiogram. Now that this patient, you know, this becomes a Tachyarrhythmias score of at least 2 or 3. He's got hypertension. He is old MI. Oh, okay, at least 2. So 2 and more, definitely anticoagulation. So does he require anticoagulation and antiplatelets, or all of the above?
All of them.
All of the above is an answer by somebody, which is absolutely wrong. Is because this guy doesn't have any symptoms of angina. He has what? He has got paroxysmal AF, he has got NSVT. So this is something to do with his substrate, not necessarily a trigger, for example, ischemia. So coronary angiogram is going to be again misleading you, and you know already he has got old MI, maybe he has got 1 or 2 vessel block, and then you will be simply be treating that, and then you will be ignoring this. In a person who has got atrial fibrillation, and then if he has got a CHAS score of 2 or more, when he qualifies anticoagulation, you should be thinking whether he requires an antiplatelet as well. As long as this is not an acute coronary syndrome, which this patient doesn't definitely have, so antiplatelet should not be considered. And in fact, anticoagulation and antiplatelets is a dangerous combination. So coronary angiogram is not okay. It should be simply be, it's a distraction. Anticoagulation and antiplatelet is a dangerous combination. So all of the above could not be the answer. This is a MI who had a syncope, who had had a ventricular tachycardia. So your aim is to prevent him from arresting suddenly. So AICD becomes the right choice. We go to case number 3. He is again a very healthy, young, 26-year-old man. He comes with a history of recurrent chest pain associated with palpitation. Well, before saying this, I could have discussed this, what you are expecting in this ECG, which is during the tachycardia. Well, 26-year-old male athlete, that means clinically he should have a normal cardiovascular status. Clinical examination should be all right. So the commonest of the palpitation with or without chest pain or diaphoresis is going to be again the same list which I showed earlier: AVNRT, AVRT, or atrial tachycardia, the commonest. And then 26 is a borderline. It could be still AVNRT or AVRT. Definitely less than 20, the AVRT becomes the commonest. So now this is 26-year-old. If it is a narrow QRS tachycardia, it could be most likely AVNRT, but well, AVRT and ATs are okay. But you should also remember that there are certain wide QRS tachycardia or ventricular tachycardia in normal people, especially young males. One particular wide QRS tachycardia is this, what they may suffer, if at all, if they have a wide QRS tachycardia, structurally normal heart, and that is called idiopathic wide QRS tachycardia. Now let's look at or describe the ECG. This is a regular wide QRS tachycardia, which has an atypical right bundle branch block morphology. Instead of a small R, big S, and R, it has almost like a monophasic R, or maybe you can say QR pattern, which is considered atypical. Some more atypical pattern of right bundle branch block are seen here. For example, in V5 and V6, in a typical right bundle branch block, you need to see a tall R and a smaller S, but here the S waves are competing with R with respect to their amplitude. Right bundle branch block, if at all, it has to have an abnormal axis. It is usually the rightward axis. Most often, right bundle branch block will have a normal axis or a rightward axis. But here, you can see the incongruity with respect to the bundle branch. Right bundle, ideally normal or right, but what you are seeing here is an extreme leftward axis. So atypicality of a wide QRS during a tachycardia is a major pointer that this is a ventricular tachycardia. So this wide QRS tachycardia in a normal heart person should be considered as a idiopathic ventricular tachycardia. And this is like almost classical picture of a idiopathic left posterior fascicular ventricular tachycardia, which is the commonest of the idiopathic ventricular tachycardia affecting the young adults. So that was this case. So it's a regular, it is relatively wide. One more thing, this particular so-called left posterior fascicular tachycardia, for example, if you take this V3, it doesn't seem to be more than say 80 to 90 milliseconds. It's relatively narrow. So especially like this, with the right bundle and a leftward axis, it's like a sine qua non of idiopathic left posterior fascicular ventricular tachycardia. So the wide QRS tachycardia could be explained as right bundle branch block, which is atypical, it's a left-ward axis. S is more than R in V6. And all these things will constitute the characteristics of ventricular tachycardia. Normal, it's athlete, clinically normal. You don't have to do an echo. Clinically, it's good enough to call this as an idiopathic ventricular tachycardia. Now we should discuss about drugs versus RFA again. If it is a first episode, well, it is quite benign in the sense it does not cause sudden arrest, etc., even though it's a ventricular tachycardia. All idiopathic ventricular tachycardia, one must remember that they are usually not the posers of a high risk for sudden cardiac death. So some reassurance regarding a better prognosis or a comfortable prognosis is required. So one can think about drugs in case there are frequent episodes of this kind, and especially the calcium channel blockers are okay. And then if the person doesn't want to have these episodes or doesn't want to take, well, radiofrequency ablation is going to give a relief up to 95% of the times. But before do the RFA, one may have to be ruling out occasional cases of supposedly to be idiopathic ventricular tachycardia to have some kind of a scar in the heart, especially when the QRS in V1 is appearing to be monomorphic. This raises the suspicion that it may not be necessarily idiopathic. And if you want to take some invasive procedures like RFA, maybe we'll have to rule out on active myocarditis or healed myocarditis. Now, this patient, he had verapamil because we diagnosed this as the idiopathic left posterior fascicular ventricular tachycardia, and we learned that calcium channel blockers are the best drugs. Um, Even though it's a ventricular tachycardia as an exception, we usually avoid calcium channel blockers in ventricular tachycardia. But idiopathic ventricular tachycardia, calcium channel blockers are indeed the choices of the drug. Well, something interesting happening here. This guy, everything went on okay. He was given IV verapamil, and then he is fine. But I'm worried. This patient now develops this. What is he developing? He is developing some remarkable T-wave inversions in 2-3 AVF, not only limited to the inferior leads. He also has significant T-wave inversion. It doesn't seem to be a prolonged QT, but it is significant T-wave inversion. So now if I ask what this is it true that this guy should not be having coronary artery disease? Is it CAD unlikely in this case? No. It could be CAD, and definitely cardiac enzymes may be elevated. Or is it a T-wave memory, or all of the above? Well, if this is a choice is given, the right answer is actually all of the above. See, this guy, who is an athlete doing great, why he should be having CAD? It's unlikely. And coronary artery disease should not have a regular wide QRS tachycardia as a manifestation of acute coronary syndrome. It's usually polymorphic tachycardia. So CAD is unlikely is the right statement there. Any kind of an insult to the heart, including the fast heart rate, may raise the enzymes to an extent. So just because cardiac enzymes were elevated does not mean this is coronary artery disease. One should remember the list of the causes of enzyme elevation. That's an important thing. So one should not get carried away that this patient had T-wave inversion and enzymes got elevated. No, the enzyme got elevated because this boy had tachycardia, and tachycardia is an insult to the cardiac muscle, and then it releases the troponin. And when you have ruled out CAD, when you are thinking enzymes rises because of the physiology, then this T-wave inversion should be considered as a T-wave memory. So answer is all of the above. So now the point here is the T-wave inversions here follow what was the tachycardia. For example, 2-3 AVF, you have had deep S waves. When the sinus rhythm is restored, the T waves remember that the QRS was negative here, and they would like to show it off that how the QRS was during the tachycardia, and then they will show T-wave inversion. The T waves remember that the R was positive here, and hence it will record R positive here. The T waves remember that in V4, V5, V6, you have had R is equal to S. So it is not as negative as this, and hence it will show T-wave inversion, but not as deep as in this. So the T-waves are smart to tell the physician what actually was happening during the tachycardia. If a ECG reader is smart, and if he thinks this T-wave inversion is because of tachycardia, he could even write down on a piece of paper what was the morphology of the tachycardia. If the T-wave inversions are 2-3 AVF are there, then the ECG reader should say that the tachycardia was a wide QRS tachycardia and there were deep S waves in inferior leads. And the ECG reader should say that most likely that wide QRS tachycardia was a right bundle branch block aberrancy because this is a positive. Look at this is a positive. And then one should be able to say that during the tachycardia, R was equal to S because these T wave inversions are less in magnitude than what is there in inferior leads. So much of a science with respect to the T wave memory. Just falling for T wave inversions and cardiac enzymes and making this guy to undergo coronary angiogram, and those angiograms showing some mild lesions, and this patient being put on lifelong antiplatelets and statin is a big crime. So we'll go for another case here. Is a 50-year-old male and chest pain 2 hours. Well, I think he's quite lucky. He would have been dead, I think, if he had not reached within 2 hours here, because look at this ST segment elevation. This is sky high ST segment depression. AVL is ST segment depression. We are not very sure about the posterior wall, etc. But this is ghastly, and then he was lucky that the patient has reached the emergency at least. Now, before the completion of the recording of this ECG, as predicted, he develops the so-called irregular, bizarre, changing in the shape and the amplitude and the axis of the QRS, and that is what we call polymorphic ventricular tachycardia. So, more than 50% of the patients with acute myocardial infarction do not reach the hospital because they would be dead because of this malignant arrhythmia they suffer. If at home resuscitation is not performed, if there's no cardioversion available, this is unlikely to revert spontaneously with such kind of an ST segment elevation. So now we are dealing with an acute myocardial infarction. Patient was lucky. He reached the hospital and then he was revived with a DC version here. So now if I give some choices for this so-called primary VF, what we call, what could be the wrong option to do? Take him to primary PCI straight away. No, he, during this episode, he was having hypertension. Okay, now the pressure is just about 90, 100. So beta blocker, already hypertension, you want to give sedate or just put an ICD. Or there are, most of them are correct and then pick up one wrong. See, the patient can be revived only when there is a revascularization is done. So for a ventricular tachycardia, there's only one indication for doing a primary PCI, and that is polymorphic ventricular tachycardia. If it's a monomorphic ventricular tachycardia, PCI or a revascularization doesn't help. But this is one which could be life-saving. Primary PCI is going to revascularize this patient, and that is the treatment of choice. Even if the pressure is 90, when there is a sinus rhythm is achieved, I think beta blockers are a great drug, because this is not only ischemia, but an immense degree of a sympathetic drive which is causing this. And the beta blockers are life-saving. Before the patient is pushed to the lab, 90, 100, don't mind, please give a beta blocker. Of course, got to give a sedation, and the least thing what you should be doing at this stage is AICD. AICD should never be recommended for a patient with a primary VF. A good management of his acute coronary syndrome, a patient could be revived, he could be stabilized, he should be sent home with whatever his ejection fraction is. Beyond 1 month or 2 months, after assessing how is he doing, then only you may consider AICD. So the wrong option among the three is AICD. What is important is primary PCI, beta blockers, and sedation. Well, you can also do something known as a sympathetic blockade by doing something known as stellate ganglion block. That is going to be also life-saving, before the patient is shifted to the lab, if the anesthetist is aware of that particular maneuver. With this, Dr. Nagaraj Desai and Dr. Basan Godappa, it's my privilege to be speaking to you, and thank you very, very much.